My name is Stuart Meisner, and now we're going to touch on oncology. General information, well, risk factors. Alcohol plus tobacco are co-carcinogenic. And you are going to see that as we go through this section that there are several different cancers that if you have alcohol and tobacco, alcohol and smoking together in the presence of each other, that just makes things a lot worse. It makes cancer develop a lot more rapidly. And that's why we say they are co-carcinogenic. Now, tobacco is the #1 cause of preventable cancer, and I think we already know that. And suspected dietary causes of cancer, well, a low-fiber diet for one thing. You see, with a low-fiber diet, you don't have as much motility in your intestines, and therefore you're retaining carcinogens longer. That's why they want us all to be on a high-fiber diet. You want a lot of fruits, vegetables, and whole grains, all that, and we're going to talk more about that a little bit later. Increased red meat consumption, increased animal fat, nitrites like in sandwich meat, processed sandwich meat, salt-cured and smoked meats. There's alcohol again. And then preservatives and additives. You know, really the big push is to eat more natural foods, like whole grain foods, things like that that have no preservatives or additives and organically grown. That sort of thing is really the very best. Now, there are increased incidents of cancer in the immunosuppressed, and that is why there is a higher incidence of cancer if you are greater than 60. You know, just the older you get, the poorer your immune system is, okay? Now, let me talk about the immune system. You know, right now in your body, all of us have cancer cells, but we have a good immune system, so what is our immune system able to do? Well, recognize those cancer cells and destroy them. However, when you become immunosuppressed in any way, then your immune system can't fight those cancer cells as well, and that is why eating healthy is so important in building up your immune system too. Now, the most important risk factor for cancer is aging. It's just the fact of life. The older you get, the greater the chance is that you are going to get cancer, simply because you have had cells in your body for so long and there are mutations that can occur and DNA can get messed up and then cancer can expose itself. But also, you've got to remember that just the older you are, the longer you have been exposed to environmental toxins too, so your risk of cancer just increased. Now, cruciferous vegetables such as broccoli, cauliflower, and cabbage are very good. Vitamin A foods, and the way I remember a vitamin A food is anything with color to it, whether it's squash, a red bell pepper, anything that is colored vitamin A food, like carrots. Vitamin C could decrease risk. Vitamin D is also important in cancer prevention, and regular physical activity is very important. And of course, protect your skin from sunlight and tanning booths. Now, African Americans have a greater incidence than Caucasians, and on that, they really don't know why. There is no specific factor that tells what the etiology is behind that. Now, primary prevention. This is a term used a lot when you are studying cancer, and these are ways to prevent the actual occurrence of cancer, like using sunscreen and just never smoking. And then we have secondary prevention, and that's when we are using screenings to pick up on cancer early when there's a greater chance for cure or control. Now, chronic irritation brings about uncontrolled growth of abnormal cells. For instance, if you have a mole in a spot that is continually being rubbed by clothing, that's irritation. Smoking is an irritation to the lungs. So there's a lot of different things that can cause irritation. Chronic reflux, somebody that always has trouble with gastroesophageal reflux disease is at higher risk for esophageal cancer because that is an irritation. Now let's look at some prevention things here. Well, first of all, the female. Monthly self-breast exam is recommended as an option for women over the age of 20. Everybody knows how important that is. Women should be taught how to do the monthly self-breast exam. Now, on what days of the menstrual cycle is the best time for doing the self-breast exam? Ask your friend. Day 7 through 12. Anytime from day 7 through 12. The key is this. After the period is just about over with, you would never want to do the self-breast exam prior to the period, because that is when you're going to have a lot of swelling and tenderness, and they're not going to get a very good exam that way. So it is after the period is just about over, anytime from day 7 through day 12. Now, if you've got somebody with that is postmenopausal and has had a hysterectomy, of course, they are not having a period. So what you do is you teach them to remember just a certain day, like, okay, well, what's your birthday? Well, February 17th. Okay, then on the 17th of every month, that's when you need to do your self-breast exam. Also, yearly clinical breast exam for women greater than 40 years of age, and women between the ages of 20 to 39 need it every 3 years. Now, when I say a clinical breast exam, I mean like in a doctor's office setting. And an annual pelvic exam is needed, and a pap smear is really only needed every 3 years if there has been no problem. That's according to the American Cancer Society. But most of the time, we get those yearly anyway because you're going to the doctor and having your yearly pelvic exam and that sort of thing. So they just go ahead and have the pap smear anyway. Now, there are 2 things you should instruct your patient not to do prior to having a pap smear. Ask your friend what those 2 things are. I heard somebody say it. No douching, first of all. A lot of people are like, oh, I got to have a douche before I go to the doctor. Well, no. That just messes with the cervical cells. The only time someone should use a douche is when it has been medically prescribed. That just messes up the cervical cells. And also, no sex prior to a pap smear. Now, y'all, you don't want other things on the slide now, do you? Ask your friend. No, all right? Mammogram. Annually, starting at age 40 with 2 views of each breast. Okay, now, before mammogram, what should you tell your patient not to have on their body? Ask your friend. No lotions, no powder, and no deodorant. No lotion, no powder, and no deodorant. See, when you have lotion, powder, or deodorant on, that can be picked up on the mammogram as a calcium deposit. It looks like a calcium deposit, and most of the time when we see a report for a patient that has a calcium deposit, that usually means cancer. So see, that would really alter the test. Now here's the deal though. Those women have not been told that prior to going to get their mammogram. So the first thing they always do when they get there is they give them a wet washcloth and they tell them, okay, now go and bathe off really, really well to make sure that they get off all the powder, lotions, whatever they have on their body off. Now then, a yearly colonoscopy at age 50 and then every 10 years after that if there has been no problem. Now the more problems you have, the more frequent you have to have those sorts of things. Now, testing the stool may also be done for primary cancer screening. All right, now for the male, well, they also need to do monthly self-breast exam. The same type of procedure needs to be done. And then a monthly testicular exam. Now, monthly because testicular tumors grow very, very, very fast. Now, the major age group that gets testicular cancer is between ages 15 and 36. So young males. And there is something that needs to be taught, well, this is something that needs to be taught early on, and be sure to teach the patient to perform the test monthly because testicular tumors do grow so fast. Now, a digital rectal exam and PSA, that's your prostate-specific antigen, may be checked annually for men over the age of 50. And we're going to talk more about that a little bit later. And then a colonoscopy at age 50, and then every 10 years. Now, general signs and symptoms. Well, caution, and I'm not going to read all those to you. You know what those are. Those are warning signs, and they are signs of what need further investigation. If someone has any one of these things, they need further investigation. Cancer can invade the bone marrow, which can lead to anemia and thrombocytopenia. So see, if you get an anemia question, you really are focusing on hypoxia, right? Okay, and then also if you get a thrombocytopenia question, you have got somebody who is going to bleed. Now, we're going to talk about bleeding precautions later in the week, but you know what those are, like use an electric razor, use a soft toothbrush. If it is a child, then quiet play, because you don't want them playing too rambunctiously. And no IMs when you are having bleeding precautions. Now, cachexia is another term that we hear used when we are studying cancer, and that means extreme wasting and malnutrition. You may hear somebody being described as being cachexic, and that usually is seen close to death when the patient is not able to eat anymore, and they have just lost lots and lots of weight. Sometimes you'll see that word used in doctors' progress notes. Now, let's talk about general treatment. Radiation therapy. Well, we've got two different types here. We've got internal and we've got external. It delivers a high-dose radiation to a localized area. Now, first we'll talk about internal. Now, another name for that is brachytherapy. Now, with all brachytherapy, the radioactive source is inside the patient and radiation is being emitted. Now, you have two types of internal radiation. You have unsealed and you have sealed. With all types of brachytherapy, the patient emits radiation for a period of time and is a hazard to others. Now, unsealed. This is when the client emits radiation, as does the body fluid. This is when an isotope is given IV or PO. Now, I think of this type, the thing I always think of is somebody that is being treated for hyperthyroidism, and they give them the isotope where they inject them. And we're going to talk more about that tomorrow. And they are radioactive for 24 to 48 hours, and then they're okay. But it can be used for cancers too. Now, the sealed or solid, the client emits radiation, the body fluid's not radioactive, implanted close or in the tumor. Y'all, part of them placing radioactive seeds into people or needles, that sort of thing, directly into the area is what we're really talking about here. All right, so let's say that you get into the test and you just can't remember all these different details and remember which emit radiation and which ones don't. Well, in general terms, do radiation implants emit radiation to the general environment? Well, if you are thinking just in general, as a brand new nurse, what would be the safest thing for you to say here? Yes, just pretend that they all do. And that is, if you can't remember the details is what I'm trying to say. Yes, they do. Like I said, some do emit radiation and some do not. They do not expect us to be oncology experts. So if you get into a bind in a test question, just pretend that they all emit radiation and you will be safe that way, because thinking like that, you won't hurt somebody, okay? Now, with radiation implants, I usually use those for treatment of cervical cancer as an example. They are inserted into the vagina and have contact with the cervix. They are high-dose treatments and low-dose treatments. They stay in place for hours to a couple of days. Now, here's the general radiation precautions you would need to take with the low dose that stay in for a few days. Time, distance, and shielding is the concept. Nursing assignments should be rotated daily so that the nurse is not constantly or continuously exposed, and the nurse should only care for one client with a radioactive implant in a given shift. You are not supposed to say, okay, well, let Sue take care of 3 radioactive implants today, okay? No, that's just not nice. Now then, precautions with internal radiation. Well, a private room is needed. Wear a film badge at all times. They need to wear their little badge that tells you how much radiation that they are getting, and they keep up with it like that. And you don't give your badge to someone else and say, okay, well, now you wear it for a while, because you are not going to know exactly how much radiation someone's been given. Restrict visitors and limit each visitor to 30 minutes per day. Now, the visitor must stay at least 6 feet from the source. Now, as nurses, sometimes we have to get really close, don't we? Well, but that is why your teacher told you when you were studying radiation, especially internal radiation like this, they told you to get your act together before you went in, right? So when you go into the room, you get what you have to get done over with, and then you get out. That's also why these people get so depressed, because they are by themselves all the time. So we have to consider that when we're talking or when we're taking care of these people too. No visitors less than 16 years of age. Visitors must stay at least 6 feet from the source. No pregnant visitors, no pregnant nurses. And be sure and mark the room with the instructions for the specific isotope telling you what to do. Wear gloves in case there's possible exposure to body fluids like urine and feces. Another important thing to keep in mind is dislodgement. Now, how can you help prevent dislodgement of the implant? Well, you keep the client on bed rest. You decrease fiber in the diet. Well, the reason for that is this. If you have got somebody who is eating a lot of fiber, that is going to distend the bowel. And when you distend the bowel, you could push out the implant, you see. All right, so they need to be on a low fiber diet. But also, we want to prevent bladder distension. That's why they will just about all have a Foley catheter to prevent bladder distension. Now, what do you do if the implant comes out, it's dislodged, and you can see it right there glowing in the bed? What are you going to do? Tell your friend, what are you going to do? Well, if you can't remember what to do, put on gloves first of all, okay? Always put on gloves. And you pick it up with forceps or tongs and place it in a what? A lead-lined container. A lead-lined container. You do not take it out of the room. You call the radiation people and let them come and get it. See, the NCLEX people, they want to make sure that you don't find something glowing in the bed, stick it in your pocket, and then walk out to the nurse's station and show everybody what you found in the bed while you radiate everybody, okay? Scare people to death. Part of the NCLEX is not just about protecting the patient. It is also about, do you have enough sense to protect yourself and the other people that you work with too? All right. Now, don't forget this patient is immunosuppressed as well. So anytime you're thinking about somebody who is immunosuppressed, do you have to consider the type of patient that will go in the room with them? Yes. But with this patient, they are in a private room, okay? But if on the NCLEX they put you in a bind and you had to select somebody, just remember that you would never put somebody that had an infection in the room with somebody that is immunosuppressed. That's just a general rule. But this person is going to be in a private room because they are radiating to the general environment. Now, external radiation, also called teletherapy or beam radiation. The usual side effects are usually limited to the exposed tissue. For instance, when you have this type of radiation, that's when you're going to be radiated in the same spot for so many days. And that one little spot is going to get really dry and the skin may start breaking down. So of course, they're going to be symptomatic at the site. Other general symptoms in general are erythema, shedding of the skin. Y'all, skin problems is what I think of first with teletherapy. Altered taste. Fatigue is a biggie, and pancytopenia. Y'all, pancytopenia, that is when all the blood components are decreased. Your red blood cells, your platelets, and your white cells, everything. Pan means everything. Also, your book says many signs and symptoms are location and dose related. For instance, if I have a brain tumor and they are radiating me here, that's when I'm going to lose my hair, have impaired taste, and have sores in my mouth. It is very local to where they are radiating you. Is it okay to wash off the markings? No. Is it okay to use lotion on the markings? No. They don't want you to put anything on the markings unless it has been ordered by the doctor. They don't want you to put anything on those markings. They have been put there for a very important reason. Also, protect the site for 1 year after completion of therapy. Well, it makes sense that you want to protect it while the area is so inflamed, right? But they have to continue protecting the site for several months later because it is still very fragile there. Good skin care. Y'all know lotions, powders, or ointments without a doctor's order. Now, chemotherapy. It works on the cell cycle. And I bet in school your teacher went into great detail about the cell cycle and all the different phases that the cell goes through when it's living. You know, different chemo drugs work in different phases of the cell. Like this drug may work in S1 or this drug may work in the M phase. Well, that is called cell cycle specific. Other drugs are cell cycle non-specific, and they may combine drugs that are cell cycle specific with drugs that are cell cycle non-specific to increase the number of cells killed. When you're using multiple drugs, we call that combination chemotherapy. We're trying to kill these cells in different phases of their life cycle. Usually scheduled every 3 to 4 weeks, and in between their chemo, they're basically recuperating, aren't they? Because that round of chemo can knock people out for a week. Then they'll tell them, now be sure to eat well this next month while you're off, because when you come back, we want to make sure your blood is built up and everything. Well, they're so sick they can't eat, all right? So it's a very vicious cycle that they get into. Most chemo drugs are given IV through a port. They usually have some type of port, right? Because their veins get so teeny tiny and hard to stick. So it's just easier on the patient to have a port. It also helps to give IV, to have a good IV access, because these drugs may be very irritating if they infiltrate. Many chemo drugs absorb through the skin and mucous membranes. So you have to be very careful when you're handling them, because you are absorbing it too. And be sure to use gloves and read about each drug and make sure you are handling it the right way. Now, the usual side effects are, well, the first thing we think about is alopecia, hair loss. Not all chemo drugs make you lose your hair, but you know that a lot of them do. Chemo drugs attack cells that are dividing most rapidly, okay? And cancer cells divide very rapidly, don't they? So do your hair follicles, and that is why hair loss is so prominent with any chemo drugs. Other things like nausea and vomiting, mucositis, that's just sores in the mouth. It is sometimes called stomatitis. Immunosuppression is a biggie, as well as anemia and thrombocytopenia. Now, a vesicant is a type of chemo drug that if it infiltrates, now we say extravasates because it is a vesicant, will cause tissue necrosis. Right. Now, it eats the tissue. Now, what are the signs and symptoms of extravasation? Well, if your tissue is being eaten away, what would be your first sign? Pain, right? That's the first complaint. Pain, swelling, and no blood return. No blood return. Anytime you are given a chemo drug, you need to look it up to see if it is a vesicant or not. If it is a vesicant, you must stay with the patient the entire time they are receiving the vesicant, because they are so dangerous. You need to be able to watch the site. So much the tissue can be eaten away that they have to have a lot of grafts done to the extremity and plastic surgery. It is very, very dangerous. Now, the number one thing to remember with extravasation is prevention. Y'all, we never want it to happen to begin with, but things do happen. Well, what do you do if someone does extravasate? What is the first thing you should do? Stop the infusion, right? Stop the infusion. Now, if you had to pick, would you choose ice packs or warm, moist heat? Ask your friend. Now tell me. Well, most of the time, with a plain old IV infiltrate, we use warm, moist heat to decrease inflammation. But if you put warm, moist heat here, it's going to make the vesicant spread. So we prefer ice packs here, ice packs here. Now y'all, in your med-surg books, they will say that certain drugs require ice packs and certain drugs require warm, moist heat. But see, I've got to think NCLEX. I'm a brand new nurse with 2 weeks of vast nursing knowledge. Do they really expect me to know all these details like that? No, because I'm not an oncology nurse expert. So the safest thing to know here, if you don't know anything else, ice packs, okay, to promote vasoconstriction. Right, vasoconstriction. I don't want it to spread to more tissue, and of course, you've got to call the doctor. And they also have what is called extravasation protocols. Different drugs have different protocols. A protocol is in place so you don't have to waste time, right? Because the longer you waste time, the more tissue is being irritated, and with the extravasation protocol, you may inject the site around the area with bicarb to neutralize it. Then they've got vasoconstricting agents that you can inject, and that would just cause vasoconstriction. So there are lots of protocols out there in the world that can be implemented as well. Now, another thing that we think about when we are thinking about somebody with cancer and chemo is immunosuppression and infection. So let's look at some general ways to prevent infection. Of course, they need a private room. Wash hands, we know that. Have their own supplies in the room. They need their own cups. They need their own everything you can think of. You don't go to the general closet and get a supply for a patient, like pull out a cup or something like that. They need their own blood pressure cuff in the room, their own stethoscope in the room, their own stuff, because you only want their bacteria in the room. Limit people in the room, like visitors and nurses. Change their dressings daily and IV tubing daily. Cough and deep breathe. You don't want them to get pneumonia, right? Now, they are already at a higher risk than the normal population for pneumonia, so we are kind of overcompensating with this person. No fresh flowers or potted plants. There's a lot of bacteria in those things. And avoid crowds. Do not share toiletries with anybody. And bathe warm, moist areas twice a day. Twice a day is usually what they say. Like under the arms, the groin area, that sort of thing. Breaks in the skin are a way for bacteria to get in. Be careful with mucous membranes too. Wash hands after touching a pet, or they say wash hands if you shake with people, which we know that. Avoid raw fruits and vegetables. There are a lot of bacteria in that sort of thing. And drink only fresh water. Stagnant water can be a source of infection. They say that if the cup of water has been sitting there by the bedside for more than 15 minutes, it's old, okay? Consider that water to have a type of bacteria in it. We want fresh water always. Slight increase in the body temp may mean sepsis. You see, in someone that is immunosuppressed, you may not see a spike in the temperature. You look for low-grade increases. An absolute neutrophil count is the most important piece of lab work because, as you know, this is a type of white cell, isn't it? Now, let's move into some different types of cancer, like specific types of cancer. The first one we're going to talk about is cervical cancer. Now, risk factors. The number one risk factor is human papilloma virus infection. Other STDs, well, repeated STDs will be an irritation, wouldn't it? Yes, chronic irritation. Multiple sexual partners makes you at higher risk for HPV, smoking, and exposure to secondhand smoke. Dietary factors such as certain nutritional deficiencies like folate, beta-carotene, and vitamin C. Prolonged hormonal therapy. Also, mothers who took DES during pregnancy put their daughters at higher risk. Family history, immunosuppression. You can't fight off cancer if you're immunosuppressed. And then sex at a young age and multiple pregnancies. Young age at the first term pregnancy is very important. Now, signs and symptoms. Well, often asymptomatic in pre-invasive cancer. You know, when that cancer starts getting out into other organs and lymph nodes, of course you're going to start getting more symptomatic. The invasive cancer classic symptom is painless vaginal bleeding. Other general signs and symptoms: watery, blood-tinged vaginal discharge, pain, pelvic, and it may occur with intercourse, leg pain along the sciatic nerve, and flank and back pain. The sciatic nerve pain is just due to pressure, okay? A 100% cure if it is detected early. Now, diagnosis. Well, what is the test that helps diagnose this? It's called a pap smear, right? Anytime you have an abnormal pap smear, they will repeat it, don't they? Yes, they always repeat abnormal paps. Now, treatment. Electrosurgical excision, laser, cryosurgery, radiation, and chemo for late stages. They can do something called conization, where they remove part of the cervix. That's for somebody who wants to try to preserve their fertility, and also it depends on how advanced your cancer is. Sometimes they just can't go in there and take out a piece of the cervix that is affected. they have to do a more radical type of surgery. Then a hysterectomy may be done too, which we're going to talk more about that in just a second. It just depends on how invasive your cancer is or what stage they catch it in. Now, uterine cancer, also called endometrial cancer. Risk factors. Well, greater than 50 years of age, and the risk increases the older you get, right? Taking estrogen therapy without progesterone, a positive family history, late menopause, and no pregnancy, also called null parity. Anybody who has struggled with infertility or has never been able to get pregnant always has a higher risk of reproductive type of cancers. Now, signs and symptoms. Well, the major symptom is post-menopausal bleeding. In other words, you've got somebody who has already been through menopause and they report that their period started one day. There is a 50% chance that it is cancer when that happens. They are going to need to be taught, hey, if you ever start having your period again after you have gone through menopause, you need to report that to your doctor immediately. Other signs and symptoms now, again, watery, bloody, vaginal discharge, low back and abdominal pain, and pelvic pain. Now, diagnosis. Well, one way they look at this is with a CA-125, which is just a blood test. And the reason they do that is to rule out any ovarian involvement. You know, in these women's magazines, they always talk about getting a CA-125. Oh, a CA-125. But really, a CA-125 can't predict that you have cancer. It may or may not be an indicator. Now, a test to evaluate for metastasis would be, well, chest x-ray, IVPs, barium enema, CT, liver and bone scans, and the most definitive diagnostic test is a dilatation and curettage, an endometrial biopsy. Now, treatment for uterine cancer. Well, surgery, a hysterectomy, a total abdominal hysterectomy. Now, total sounds like they're going in and taking out everything, but really, they are just going in and getting rid of the uterus and the cervix with a total, okay? If they want to get the tubes and ovaries, other things have to be written on the op permit as well. You have a bilateral oophorectomy, bilateral salpingectomy. Now, with a radical hysterectomy, they remove all of the pelvic organs. So your client may end up with a colostomy or an ileal conduit. Well, they had to take out the bladder too. The greatest time for hemorrhage following this surgery, and we're talking about abdominal hysterectomy in general now, the greatest time for hemorrhage following this surgery is within the first 24 hours. Why? Pelvic congestion of blood. Pelvic congestion of blood. Just due to the nature of the surgery, you've got a lot of blood rushing to the pelvis. Now, let me tell you something. The major complication of an abdominal hysterectomy, is hemorrhage. This isn't on your handout. I'm just talking, but abdominal hysterectomy, think hemorrhage. Vaginal hysterectomy, think infection. Vaginal hysterectomies, think infection. All right, the next statement says they will probably have a Foley. If she doesn't, you better make sure she does what in the next 8 hours? Void. Anytime someone has had surgery, y'all, you know that if you don't have a Foley catheter in place, you need to be checking for bladder distension. Because they're still out of it from the anesthesia and that sort of thing, and they may not recognize when they need to void. That is very important. It is especially important here. Why is it so important to prevent abdominal distension after this surgery? Because we don't want any tension on the suture line, right? The suture line. This can lead to wound dehiscence and evisceration. So if you go into the room and the incision is separating, that's dehiscence. But if you have organs actually coming out, that is evisceration. So you walk in the room and you look under the dressing and the patient is eviscerating. Tell your friend, what do you do? What do you do? Well, go get somebody that knows more than me? No, you don't leave the patient first, okay? That's the first thing I want to remember. Now, it's okay to get on the call light and ask someone to come and help you, but you need to make the NCLEX people happy and reassure them that you are not going to leave. Now, what if it said as an answer, hold slight, gentle pressure with sterile gloves on. What would you say? What are you telling the NCLEX people you are about to do here? I'm going to push everything all back in, right? Well, no, you don't do that. No pressure. You put 4x4s all over it, sterile saline 4x4s to keep the area moist, and call the doctor. And we have already agreed that we are not going to leave the patient. Now, why do we avoid high Fowler's position in this patient? Because that will make more blood go where? To the pelvis. And we don't want more blood going to the pelvis. They may have an abdominal and a perineal dressing to check. So just know that you may have 2 dressings to check. Okay, now, as the patient is at risk for pneumonia, thrombophlebitis, and constipation, what is one thing that you can do to prevent these complications? Ask your friend. Now tell me. Y'all, I said I wanted one thing. How does coughing and deep breathing help constipation? It doesn't. That's why I made you pick one thing. Early ambulation is the answer there. Early ambulation will hit all 3 of those things. Now, don't get me wrong, I like coughing and deep breathing, but I was trying to make you pick one answer that would hit all of them. Now, avoid sex and driving. Let's get one thing straight. I don't mean at the same time. I just mean for a period of time. Also, avoid a girdle. That's just going to cause more pelvic congestion. And also, stay away from the douche. Infection is what I think here. Any exercise, including lifting heavy objects that increase pelvic congestion, should be avoided. What if you've got somebody that has small children at home, and should they be picking up these children? No, because when if you pick up too much, they're going to bleed. Is it possible that the patient could hemorrhage 10 to 14 days after this surgery? Yes, or we wouldn't have typed that big old long sentence there now, would we? Yes, it's there for a reason. Yes, they can hemorrhage. Now, is a whitish vaginal discharge okay? Yes, y'all, whitish is okay. That's normal. I worry if it starts to change colors, don't I? Now, okay, do we prefer this patient to have a shower or a bath? Shower, because baths promote ascending infection. Baths promote ascending infection. Now, other treatments that we have in your handout are radiation, like intracavitary radiation to prevent vaginal recurrence, chemotherapy, and estrogen inhibitors. Maybe if the client has a tumor that is real estrogen dependent, you will inhibit estrogen in these people with these drugs that I've listed there. All right, let's look at breast cancer now. Known risk factors. Well, one has a 3-fold increase of developing breast cancer if a first-degree relative, like a mother or a sister or a daughter, had premenopausal breast cancer. Now, so the history is real important here. High-dose radiation to the thorax prior to age 20, like x-rays and that sort of thing, and period onset prior to the age of 12. Menopause after the age of 50, and again, somebody that doesn't have any pregnancies, they sometimes call this null parity, or the first birth greater than 30. The longer you wait to have a baby, the greater the chance is of reproductive types of cancers. Signs and symptoms now. Well, a change in the appearance of the breast, or a lump, or an orange peel appearance. Axillary lump. Now, what will the breast look like? Well, you may see some retraction, or like we said, the orange peel. That just means dimpling. Now, when the breast tissue is retracted, that is the tumor inside that is pulling on the breast tissue, okay? Also, discharge from the nipple could be a sign or a lump. Now, here's a critical thinking exercise. Let me say one more thing about breast assessment. When you are teaching somebody about a breast assessment, they need to learn about what's normal for them, because everybody has got lumps and bumps. You need to learn what is normal for you, but we always say to get into the shower because your hand will slide more easily over the breast when you're all soapy. They also need to be taught to examine under the axilla too, known as the tail of Spence. The tail of Spence is where 48% of breast tumors occur in the upper outer quadrant. 48% of breast tumors occur in the upper outer quadrant. See, the upper outer quadrant that extends under the axilla is known as the tail of Spence. Now, treatment. Well, surgery. Post-op care is where we're going to focus on now. We're going to check for bleeding by checking the dressings. Now, checking the back. Why are we checking the back, y'all? Well, if the surgery is in the front, why are we checking back here? Pulling can occur. Remember, when you have pulling of blood, it doesn't always come out in the sheets where you can see it. You may have pulling of blood in the tissue back here. Also, we're going to check for our hemovacs, and they might have some Jackson Pratt drains that we need to be checking on as well. Anytime you've got drains, y'all, or suction, you need to look for sudden increases in bleeding or the amount that is there. Elevate the arm on the affected or unaffected side. Ask your friend. What you think? Hey, y'all, what does the unaffected side have to do with it? Nothing, right? So you elevate on the affected side. The affected side, the surgical side, because many, many times, do they take out lymph nodes too? Yeah. And when you take out lymph nodes from any area, swelling is going to occur, and that's why we're elevating, okay? Also, that is why many times people will come back with an ACE compression bandage on their arm to decrease edema too. It just depends on the doctor, but the elevation is very, very important. Now, associated nursing care. Stay away from the arm on the affected side for the lifetime of the patient. They need to be taught that they protect this arm. For instance, no constriction, so no blood pressures. Also, when I think of constriction, I think of maybe blouses with elastic or wearing a watch. They don't even want you carrying a purse on that arm anymore because that is a type of constriction. No blood pressures, no injections, wear gloves when gardening, watch small cuts, no nail biting, no sunburn, no IV, no nothing. See, if you don't have your lymphatic system over here anymore, do you have the ability to fight infection like you used to? No. So one little nick can turn into a major wound infection from now on. Other things to remember post-mastectomy: brush hair, squeeze tennis balls, wall climbing, flex and extend the elbow. Now why? Well, this promotes new circulation. New circulation, sometimes called collateral circulation. Now here's a critical thinking exercise. Now day one, post-op, you come into my room and you say, okay, Stuart, I need you to brush your hair. So you give me a hairbrush and we're going to pretend I have really long flowing hair. Now first of all, I'm going to try to take it with the opposite arm that doesn't hurt, this arm, okay? But you say, no, I really mean on the affected side, the surgical side. So I take the hairbrush. Now how am I going to brush my hair day one post-op? Like this, right? Because it hurts. I'm trying to protect it. And that's why I get frozen shoulder. But that is why we have them doing these other things too, like the wall climbing exercise. Because every day you want them to go up the wall just a little bit farther. All right, you want them to look at the incision. And that is not something they can do immediately. For different people, that takes different amounts of time. And that's one way how you can tell if they are adapting and coping by how much they want to participate in their care with their dressing changes. And many women this day and time, they go ahead and after they have a mastectomy, go ahead and have an augmentation at the same time. That really helps with the body image changes. Reach to Recovery is the name of the support group. Now I also want to talk about lymphedema. This is just so important. You know, if you don't have a lymphatic system, we've already said that you can't fight infection over here, okay? So the area is going to start to swell, right? Well, that is two of the most important functions of the lymphatic system, is to fight infection and promote drainage. So that's why they really have to protect this extremity, and you know, forever. They may have to support that extremity, and it depends on how many lymph nodes were taken out. But with time, they should be able to get where they can hang their arm down. Some people don't ever get to that, but most do. Now, other treatments like chemo, like Taxol and Adriamycin, Hormonal therapy. These drugs lower estrogen effects on the cancer by various methods. For example, you've got estrogen receptor blocking agents like tamoxifen and estrogen synthesis inhibitors like Lupron and Zoladex. You know, they just really inhibit any type of estrogen, and it's like putting them into a menopause because any kind of breast tumors are estrogen dependent. And radiation may have to be done too. It just depends. All right, let's look at lung cancer. Well, risk factors. The leading cause of cancer death worldwide, the 5-year survival rate is only 16%. That is not very high. And of course, the major risk factor is going to be smoking. Now, when you have stopped smoking for 15 years, the incidence of lung cancer is almost like that of a non-smoker. But they're never going to say it's just like that of a non-smoker because you still have a history of smoking, but it's almost like that of a non-smoker. Now, signs and symptoms: hemoptysis and shortness of breath or dyspnea. Now, when you have somebody that presents with hemoptysis or shortness of breath, many times that gets confused with TB. But something about TB, though, that makes it different is that TB people have night sweats too, night sweats. Other signs of lung cancer are hoarseness, cough, change in endurance, chest pain, pleuritic pain on inspiration, a displaced trach, and this may metastasize to the bone. Now, how do they diagnose this? Well, one way is with a bronchoscopy. Just go in there and look. NPO pre and NPO until what returns? The gag reflex. Now, don't get me wrong. When they come back from this procedure, it's okay for them to not have a gag reflex. That's normal. Anytime they're passing a scope through the oropharynx, they spray stuff back there to numb it up. So when they pass the tube, you won't gag so much. But the key is this: if they don't have a gag reflex, you keep them NPO. They could aspirate. It'll come back on its own. Now, watch for respiratory depression, hoarseness, dysphagia, or sub-Q emphysema. Now, what is sub-Q emphysema? Air under the tissue or air under the skin in the tissue. Air in the tissue. I bet your teacher told you something like this: it feels like Rice Krispies sound. Does that make sense? It's kind of weird. It feels like Rice Krispies sound. Y'all, that's the air popping and cracking under there. If you ever have a patient that has air in the tissue after a bronchoscopy in particular, they had to have perforated the airway, right? The air is leaking out into the tissue. That's an emergency. You're not going to just sit there and say, oh, you know, you've got the little crispy thing going on. No, something needs to be dealt with immediately. Also, is it normal or abnormal to have respiratory depression when they come back from this procedure? Ask your friend. Now, I know what's going through your minds. You're saying, well, they gave them that stuff to make them pass out, to knock them out, sedation, right? So, of course, the respiratory rate is going to be decreased. Well, a decreased respiratory rate is different than respiratory depression. That's an example of the way they will get you on boards. They make you think, well, yeah, they had that medicine to put them to sleep when they put down that scope, so of course they're going to be breathing more slowly. Well, slowly is different than depressed. When you see the words respiratory depression, that means depressed less than 12 times per minute. So are we worried at this point? Yes. So no, it is not normal to have respiratory depression after a bronchoscopy. Now here's my rule for breathing, and I'll give you a second to finish writing down what you're writing down. And I want to tell you this, and afterwards you're going to think, well, that is just so stupid. But you'll see what I mean when we start looking at test questions. The respiratory rate should always be perfect, period. Now you remember that when we start looking at test questions later on in the week. If it is too low or too high, there is a problem, especially after an airway test. All right. Now, sputum specimen. When is the best time to get a sputum specimen? First thing in the morning. We like fresh specimens, don't we? Don't we? Yeah. Those secretions have been accumulating all night long. That's what we want. Is this a sterile specimen? Yes, it is. Now, I know what you're thinking. You're thinking, well, when they cough and the sputum comes through the mouth, that it is no longer sterile. Well, you're right. When it comes through the mouth, it's not sterile anymore. But do we still consider it to be a sterile specimen? Yes. You've got a sterile cup, you've got the whole bit. Now, when they've got the sterile cup there, do you want their mouth touching the cup? No. You just contaminated the specimen. Now, what should you have your patient do first? Thought I heard somebody say cough. Somebody at least thought it in their head. Before they cough, what should they do? Rinse their mouth out with water. Y'all, we are trying to decrease the bacterial count in the mouth. So when the sputum comes through there, it won't pick up mouth bacteria is my point. All right. Other ways they diagnose lung cancer? Well, chest x-ray, CT scan, and an MRI. And the treatment, well, surgery is the main treatment for stage 1 and 2. For stage 1 and 2 is going to be surgery. Now you've got a lobectomy and you've got a pneumonectomy. Now a lobectomy is just when they take out part of the lung, right? Yeah, just part of it. You're retaining some of your lung. They're going to have chest tubes here because do you want fluid accumulating around the small part of the lung that you have left? No. So they're going to have chest tubes with that one because you're still going to have lung over there, okay? You want the surgical side up. So let's say you have 3 lobes over here. Now, you took out one of the lobes, and now you've got 2 lobes left. They want what's left of that lung to be able to expand so it won't get pneumonia. Now, what is a pneumonectomy? Yes, the entire lung, removal of the entire lung. Now, position on what side? The affected or unaffected? Ask your friend. Now tell me, the affected side, the surgical side, good lung, only lung you have left, up, right? Yes. If you put me on the only lung I have left, then the only lung I have left is going to fill with fluid and I'm going to get pneumonia. So you position me with the good lung up so it can expand and not get pneumonia. So position on the affected side. You want the surgical side down. Now, chest tubes. Why do they not have chest tubes, y'all? Well, there's no lung. Where do chest tubes go? In the pleural space. Well, if your lung is gone, you don't have a pleural space anymore, now do you? Now, I want to emphasize, we still avoid severe lateral positioning. In other words, when you turn them on their side, you don't turn them all the way on their side because that can promote a mediastinal shift. And everybody knows that's bad, right? Yeah, we're going to talk about that later tomorrow in the respiratory section.